Good morning, everybody. Thank you. So a quick introduction then on what keratoconus is, and hopefully also highlight what's to come throughout the day, throughout the seminar. And I'm sure many of those who are patients sitting in the audience are already very knowledgeable about this condition. But for family and friends, there are times that it's hard to communicate what this condition does and what it is. And so I'm hoping that we can highlight some of those common questions that I get asked when a patient comes in with family friends regarding what keratoconus is and what it does to a patient. So, a normal cornea is very similar to, say, that of a magnifier. When you sort of trace the contour of the thick magnifier, it's very smooth, or it can be compared to the dome of a watch face. And the roundness of the shape is what gives it power to the eye and able to focus the light into the back of the eye where the retina is and have the message then transmitted through your nerve to your brain. This is a side profile of a normal eye, and by normal I just meant it doesn't have any condition on the cornea. And you can see that it's relatively round and it's smooth curvature. And as if the roundness is a little too round or not round enough but smooth regardless, then it sometimes focuses the light a little bit before or a little bit after the back of the eye where your retina is, and therefore sets up conditions like nearsightedness and farsightedness. And if the curvature is very different, sort of looking at this picture here where almost like a football, where one side you have a curvature a lot more so than the other, then it sets up a situation where people have what we call astigmatism. And that means one position of your cornea has a different power than the other, so your glasses needs to have more than one prescription on your lenses to correct for that. And the reason I want to mention that, even though it's very basic, is because this is a term that seems that a lot of times gets confused and creates some confusion both in patients and doctors as well, in that in the early stage of keratoconus, most people are being told that they have astigmatism, because in very, very early stages they could look very similar. As the eye is protruding forward, it may take on that football shape that I'm showing you, and although their vision cannot be completely corrected to what people with regular astigmatism is, they're often told that that's what they have and therefore possibly could defer treatment. But that's that is a very common confusion and complexity in diagnosing keratoconus, and that's why I want to mention that. So in the keratoconus, when the cornea is weaker and weakened by whether genetic factor or external factor, and some of that we'll talk about a little bit later, it gets weaker and gets a little bit thinner. The tissue starts to disappear a little bit, and therefore it's sort of like outpouching on a tire where the area is thinner, where you're going to get a little bit of protrusion or bulging forward or outward. And so it sets up a situation where the eye, when it moves forward, looks a little bit triangular, a little bit like a cone, so we call it keratoconus. Kerato for collagen or of the eye, so it looks like a cone when it's absolutely more severe. So you can think of a normal cornea as layers and layers of pancake, where you put syrup and in between each pancake, like making a hot stack, and you kind of let it cool and it all gets stick together by sugar and protein. So that's basically what your cornea is made of. It's pancakes with lamellars of collagen fibers and being glued together by cellular substances like sugar and protein. And so when those cells are destroyed or lessened, then that's where your tissue gets weaker and sets off the situation known as keratoconus. So as you can see here, no matter, this is a bridge, by the way. So no matter how strong, I know, right, pointing out the obvious, in case you cannot see that's a bridge, it is a bridge with a car on it. So no matter how strong we consider a substance is, if there's enough of an external interference, whether it's due to internal weakness, or that the external force is stronger than the internal structure, something can collapse, like this bridge, right? That's the Tacoma Narrows Bridge that collapsed in 1940s. in Seattle. So what I'm trying to say is, therefore, it is possible that whether genetic predisposition from keratoconus that weakens the cornea, or that the external trauma, such as possibly even eye rubbing, that sets off more enzymatic digestion or thermal, as in heat, digestion of the tissue, it is possible that that can advance the keratoconus. At least we consider it a big factor that can be modified. So definitely we're going to talk about this a little bit later as well when we discuss contact lenses, in that it is the fitting of the lenses matters, as well as avoiding trying to rub your eyes, and therefore controlling whether it's dryness or other conditions such as allergy, that sets of itching responses and scratching responses can be avoided or reduced. So as the eye moves forward, as you can see, it creates a situation where it's no longer as round as before, and it's not a smooth shape. And therefore, as light encounters or interface with the front surface of your cornea, now that the light ray is not going to be properly focused in the back of the eye where the retina is. And it's going to set off situations where people feel like either things are very blurry, regardless of what kind of glasses prescription they're given, because now it's a complicated situation that's more so than your regular astigmatism. So your regular glasses that can possibly have a couple different prescriptions on the lenses will no longer be able to push all the points of the light rays in the back of the eye and bring about one single clear focus. And it's due to this shape of the eye that encounters the light and bend it, or we call it refract, light rays differently, and therefore does not properly deliver all the strength of the light signal or the message into the retina in one place to give you good vision. So, that is basically in a nutshell what keratoconus is, and it occurs naturally. The prevalence, I should say, I'm not sure naturally is the word, but it occurs, prevalence rate, or the percentage of population that can have this condition or being diagnosed at any given time, we call that prevalence, is about 1 in 2,000. And that's a very sort of classic number that's quoted from many medical literatures that dates back to in the 1800s. And however, the advancement in technology, the awareness of this condition, at least that's what we hope to do today, seem to be pointing towards the fact that there may be some region that have much higher prevalence or percentage of population that have this condition. It could also be that maybe overall globally it is much higher than 1 in 2,000. It could be maybe due to poor technology, poor documentation. People don't seek care when they think that they're just getting old and that's the way their vision is, or they've always lived with this type of vision. They don't think that anything's wrong with it. So for whatever reason, this number is likely higher than the 1 in 2,000 that's commonly being quoted. And typically, the life cycle of a keratoconus patient starts during adolescence or early puberty. That's one reason we think genetic probably has a lot to do with it, because of the different hormonal levels in your body at that time. And it seems to progress as a general cycle progress until about 3rd or 4th decade of life. So on average, according to different studies, the mean age can range from anywhere from 9 years old to about 38. However, that does not mean that this condition cannot progress after that. It's a stop-and-go disease. It can progress at any time in your life. Again, possibly eye rubbing in different stages of your life can destabilize your condition, even if you have been stable for a while. And therefore, there's things that you should be monitored, and there are things that we should definitely learn to control. So this is the genetic history. 6 to 24% of patients have reported family history. We certainly have a lot of patients coming in as well saying, all my siblings have it, my parents have it. Now, however, it doesn't have to go from generation to generation. And that likely is that's the reason why it's very difficult to find an allele or gene that actually is responsible for keratoconus, because it doesn't have a predictable pattern as far as we can find. However, I know companies that are working on genetic testing through an oral swab. So obviously they're working on the DNA sequence and see if they could actually find some secret and unlock that. So looking forward to that. And I mentioned that different regions of the world have been found to have different level of prevalences, and therefore it is possible that even though we've never thought that there could be a racial or ethnic differences, that there actually can exist. And it makes sense because environment is different depending on which part of the world you're in. So most commonly, though, I guess the one good news or silver lining about keratoconus is that it's not a disease that can lead to total blindness, as in total darkness, and that's usually what most people are concerned about when they come in with this condition. It's because the light ray still passes through your cornea, as I've shown you, even though the shape is distorted. So you don't see very well, it's extremely blurry. You may have other visual symptoms that I'll talk about when we go through contact lenses, but light is coming in unless there's heavy scarring, which people do get with keratoconus. As the condition advances, they may have scar tissue that can build up as their internal tissue arrangement is changing. So that's something that, again, we will monitor our patients for, but typically it's not a disease that you lose your sight completely. However, there are other conditions that, although never found to directly cause keratoconus, but they are associated, such as atopic diseases, which is just more of a severe spectrum of allergic diseases. And so patients have been observed with keratoconus to have very intense response to this type of condition, in that they rub their eyes really hard, which is why one surmises that that may be a great risk factor to destabilize such disease. However, like I said, nothing has ever been found to be directly causing keratoconus. However, we know molecularly or at a cellular level what's happening, and that is, again, as I've said, thinning causes weakness, causes outward bulging, just like a tire with a spot that's thinner, that's worn out a little bit, and the air pressure kind of pushes that out into an outpouching. So making the tissues less and less resistant to whether thermal digestion or your inflammatory molecules in the tear film of keratoconus patients have been found to be much higher compared to patients with no keratoconus. So it is possible that there's cellular digestion that is going on very slowly. Obviously doesn't cause pain because it's happening inside of your cornea, but that's a possibility. So again, that's something that we want to control on the surface of the eye if we find that there are other diseases or at least other process that is happening at the same time on a keratoconus patient eyes. So again, avoid eye rubbing, and that has sort of set up a question of, well, is it possible that if we tell keratoconus patients that they often have to wear what's called hard lenses, or really called gas permeable lenses now, because hard lenses is a material that's many generations ago. They're a little harder, a little stiffer, have a little bit more weight to it. Is it possible that it also sets off a little bit of shearing force whether the patient's rubbing their eyes on top of the contact lenses, or just naturally the lens isn't fitting the shape of the eye very well? Could that possibly also set up a situation where you have enough external trauma, micro trauma nonetheless, but external force that is destabilizing your condition? No conclusion has ever been reached in literature, but there are evidences to show that a very poor fitting lens can possibly, in my mind, accelerate scarring process, or at least is somewhat associated with scarring process, come about a little bit earlier in keratoconus patients. So absolutely very important to have proper utilization of contact lenses. And we'll talk about that a little bit later too, right after lunch or right after morning break, I believe. So the conclusion is, obviously, don't rub your eyes. Whatever it is that's causing you to want to rub your eyes, communicate that with your eye doctor, because that can be, most of the time, can be controlled very easily with interventions or or eye drops and medications. So treat your allergy, treat dry eye like we talked about. Sometimes that may require medication that you have to take by mouth more than eye drops. And get the best fitting that you can. Not only does that give you the best quality of your life because you're going to get the best vision possible, but also you want to pay attention to whether or not a fitting is conducive to give you the best health on the surface of your eye, as well as obviously and hopefully the best comfort that you can get, so that you can go about your life. We don't know if prolonged exposure and in an uncontrolled fashion to UV light, that may set off some tissue distress and DNA distress, and therefore it is advisable to always wear sunglasses, even if you're wearing contact lenses. Some people, once they get rid of their glasses, they're happy in their contact lenses, they don't seem to remember that they should still put on their sunglasses when they go out. And it is possible that uncontrolled exposure to UV light can set off enough stress that, unlike the cross-linking that we're going to talk about later, can set enough stress level, especially cumulatively across your lifetime, to do something to the advancement of your keratoconus condition. And diet obviously is very important as well. So we talked about astigmatism as a very confusing optical sign for early keratoconus patient versus non-keratoconus patient who both have astigmatism, and therefore better instruments obviously is needed, and we'll talk about that in a little bit, and in terms of diagnosing keratoconus patients. But these are some of the clinical signs that we see, and you can see that sometimes the tissue can get so thin that the back layer of your cornea actually breaks a little bit, and you can see here that's the back layer, and fluid rushes in from inside of the eye. We call that eye drops, and although it can be a painless situation, it is very scary to wake up with that for keratoconus patients, because all of a sudden your vision drops with no preceding sign from the night before, or sometimes just as you're walking on the street and there's no pain and you don't know what's going on, your contact lens no longer helps you because now the structure of your cornea changed. So that's one thing that, and again, that we can treat and manage and watch you for if that does happen. So how do we diagnose keratoconus patients then before we go on to the next topic? And obviously, if I'm telling you that the tissue gets weaker and thinner, then testing the thickness of the tissue is one way in our clinic that we use to diagnose and monitor this condition. And we can do that by either using an ultrasound probe or a very complicated computerized system that has an algorithm to tell us not just the shape of the eye at the front, at the back, but as well as the thickness of the eye, which is that's what this color map is trying to show here. We can measure the actual shape of the eye using this instrument in a room called keratometer, and obviously as the shape bulges forward, the curve changes, as I've talked about. So that's something that we like to measure, and at the same time, this is sort of the doctor's view of when we looked into the keratometer. You can see that the surface is very distorted because the circles are now all have changed shape, and that's one way that we can use to diagnose keratoconus patients. This is the computerized system that I had just talked about. Very similar to if you open a book on geography and they're looking at surveying the height of mountain ranges and using different color to denote different height. That is basically what we're doing here as well. For North American scale, because every country is a little bit different, typically the warmer color series like the red and orange and the peach, that means that the eye, at that point, the eye is a little bit higher or had bulged out forward. The cooler series like the green and blue usually means that it's a little bit sunken in or flatter. And you can see that, again, those circles are not completely round on this cornea, meaning that this patient has keratoconus. Obviously, the area that comes out can be very different. If this were the central area of your cornea, it can come out more in the center or a little bit further away from the center, and that has different implication to the level of vision one can achieve, and as well as how the difficulty of fitting a contact lens. And we'll talk about that again a little bit later about when we reach the topic of contact lenses. So this is just one way that, again, that we can use to monitor if somebody's getting worse or not by utilizing this complex algorithm that tells us whether or not the eye is bulging forward. And as you can see, when we compare the map, I'm sorry that the last one's cut off a little bit, you can see a little bit of redness, however, peeking through the last map, telling us that when I compare 2009 to 2010, 2010 is even bulged forward a little bit more because of the redness. Whereas after we treat with whether cross-linking or in this case intacs, and again, where Dr. Hirsch is going to talk about that a little bit later, you can see a comparison map of the keratoconus area is getting smaller before and after it gets smaller, and if we compare point by point, that the cool series, the blue color, show through more, meaning that the shape of the eye has been pushed back a little bit more, and therefore can bring about improvement in one's vision. So obviously then it's your vision is more than just your eyes. As I had alluded at the beginning, your signal goes from your nerve to your brain, so everything has to work concurrently very well at the same time. They all have to be healthy. So one reason to not just don't go by just your vision. Obviously, your vision is very important, but need to have your eyes examined and dilated on a regular basis, so that the health of the entire eye can be, and hopefully also your brain can then be documented. And so another instrument that we use then to diagnose keratoconus is to measure how much visual noise they are getting. And I mentioned that the distortion in your cornea bends light differently. It sends a very scattered signal to the back of the eye, and therefore if we're able to measure that, we can then hopefully better understand what the patient is experiencing. And in a little bit, you also see that if that technology, we can maybe possibly also incorporate in contact lenses to make people see even better in contact lenses. So just quickly, as the light ray leaves the pupil and is being picked up by a sensor, it tells us how much scattering is happening, how much visual noise that a patient is experiencing. And therefore, that is also another way that we creatively use to measure and monitor, diagnose keratoconus, as well as monitor the state of keratoconus. And biomechanics, the strength of your cornea, as I've mentioned, the tissue gets thinner. As it gets weaker, it gets thinner. So therefore, if we can somehow measure the weakness or the strength of the cornea, maybe that's another way that we can use to diagnose keratoconus. That's a very new technology. We have been a study site for this technology for many years, but it's something that's in the recent 2-3 years have been talked about in medical literature about what these numbers mean and how they can be applied towards diagnosing people with conditions such as keratoconus and maybe even glaucoma. So that's something that's very interesting. So in conclusion, we want to keep your eyes as healthy as possible. We would like to understand what all our patients are seeing so we can help them to find a way to give them their best vision and best quality of the life back to them. And these are the instruments that we like to use to monitor our patients. There will be more to come. We are interested in doing more research on how to best serve our patients as you will hear throughout the day. And I think that is all that I have. I'm sorry, I know this topic is heavy and it's not interesting, but I hope it didn't hit you like a watermelon. Thank you.